Therapy and treatments. Basic questions we're going to be addressing in this lecture. Why do people seek psychotherapy? What are the various types of mental health professionals involved in the provision of therapy? What are the major categories of therapy, their goals, processes, methods, and relative effectiveness? All right, so who seeks treatment? About 15% of the adult population in the United States will seek psychotherapy in a given year. There's a couple of different reasons why people will seek therapy. Non-clinical issues and clinical issues. Think of the non-clinical issues as those issues that don't have a particular clinical diagnosis. So, for example, somebody might seek the help of a mental health care provider if they're feeling dissatisfied with their life. They want to make a change and they need some support. They might be having issues in their relationships, in their work. Some people start off on a particular career trajectory and find that it's not working out, and so they need some support in transitioning into some other area that they might find more satisfaction with. And they want to grow as individuals, and sometimes it helps to have a third party to help you kind of take a look at your life and your patterns and that sort of thing and support you in changing, becoming a different kind of person, having a different kind of life. Clinical issues are those that require and have diagnoses. So depression and anxiety are the most common that you learned in the last module, and there's others as well. The largest barrier, the single largest barrier from people seeking help when they might need it, is this idea that that there's going to be a once you're labeled with some sort of problem, having some sort of problem, which is part of the diagnostic process. If it's a clinical issue, then there's a stigma attached to that, and the fear is that there will be prejudice and discrimination, and essentially negative feelings and actions towards somebody once they've been labeled as having some sort of problem. So some people who might benefit from help don't actually seek it out. So who are you going to see if you seek help? Well, there's a number of different individuals who are professionally trained to support people in finding solutions to their problems. So we have the clinical and the counseling psychologists, psychiatrists, and the social workers, the clinical social workers and counselors. So the clinical and counseling psychologists have very similar training. To call yourself a psychologist, you have to have the doctorate or the PhD. In most mainstream academic programs, PhD programs, they're based on what's called a scientist practitioner model. That is, a doctoral degree, a doctorate is a research degree. So you're going to be doing research. So you're going to be trained as a researcher, but you're also going to receive training as a clinician. So most clinical and counseling programs have internships, and many of these are APA approved internships that the person experiences. The training is quite similar. I would say that the main difference is, as a counseling psychologist, maybe you're getting more training with respect to those non-clinical issues, whereas a clinical psychologist, the emphasis may be more on testing and diagnosis and treatment of the diagnosable psychiatric or psychological issues. The psychiatrist has the MD. That's the main difference between a psychologist and a psychiatrist, is that the psychiatrist has an MD. They go to medical school. They specialize in psychiatry. They can write prescriptions. Workplace differences. Psychiatrists might be found in psychiatric hospitals or community mental health centers, seeing people with often chronic psychiatric disabilities for which they prescribe medication and are often constantly trying to find the right medications for individuals. Social workers and counselors have master's degrees. So these are good options for people who are interested in being scientists or researchers or possibly working at universities, even though some people with master's degrees do work at colleges and universities. The master's usually takes 2 years, whereas the PhD and the MD can certainly take 5, 6, or more years to complete. So clinical social workers you can find employed in hospitals, for example, that have psychiatric units, Often there's a social worker that handles the discharge process. This is a very important uh, role in that whole treatment process. That is, somebody's admitted to a hospital, they're observed, they're diagnosed, and then ultimately they have to be discharged out of the hospital. So that discharge planning is very important. Clinical social workers can be found in community health, mental health centers, working with people, frontline mental health, so to speak. Um, Counselors, you can get master's degrees in clinical and counseling psychology and start your own practice. Out in California, for example, I used to live there. A popular uh, career track was the master's in counseling or clinical psychology, and then you'd get a certification as a marriage, child, and family counselor. And this is a licensure that is given by the state, and you have to sit for a pretty rigorous test for that. And then once you're licensed as a marriage, family, and child counselor, you can open your own practice and work with people. So if you're going to seek treatment, it's one or the other, some combination of these individuals that you're going to seek. All right, concept check here. The primary difference between a clinical psychologist and a psychiatrist is that the psychologist has the blank and the psychiatrist has the blank. Correct answer is B. Psychologist has a PhD, psychiatrist has the MD. All right, so let's look at the major types of therapies. We've got biomedical, behavioral, cognitive, and cognitive behavioral. And then we have the insight therapies. These are the ones you're probably most familiar with, the talk therapies, the psychodynamic or the psychoanalytic approach that we get from Freud, and then the humanistic approaches, Carl Rogers in particular. So we're going to look at these. Biomedical focus primarily on next time, at least the most common one, which is treatment with drugs or medicine. We'll look at a couple different ones in this lecture, but we're going to be looking at these therapies in turn. So first, the biomedical therapies, and we're going to look at this through a case study method. So here's case number one. Mrs. Bond is a recently divorced 46-year-old woman. She left her husband of 20 years because she constantly felt lonely and empty around him, and he didn't want anything to do anything with her any longer. They had not had sex for 5 years. She is agitated and complains of appetite loss and low mood over the previous 2 months. During the examination, she is teary, complains of inability to sleep, loss of interest in work and leisure activities. She has been stressed and unable to function at work. The patient denies any suicidal thoughts. Physical examination and other investigations are normal. So what do you suppose Mrs. Bond is suffering from? What's your diagnosis? Probably major depression. So how would we treat Mrs. Bond? Well, because of the severity of the symptoms, looks like she's unable to function at work and having trouble enjoying life and so forth, and she's not having any suicidal ideation, but she's certainly struggling. These meet the criteria of major depression, so you decide to initiate antidepressant therapy. And again, we're going to be talking about medicine in the next lecture. But this is probably what you would do, an approach you would probably take for somebody who's really struggling with depression, probably get them on some sort of medication, and then certainly recommend that they seek some other form of psychotherapy to help them sort out the possible environmental causes of what's contributing to this person's depression. Clearly, divorce is an extremely stressful event and major stressor in somebody's life, and so you certainly want to provide some support for talking about that experience and what it means for her in the present and possibly for the future. But stabilize on meds and then certainly get into some sort of talk therapy probably. The goal of the biomedical therapies generally is to reduce the symptoms associated with psych disorders by treating them at the biological level. So this is when you consider etiology. In some cases, depression is organic in origin. That is, it has to do with a problem at the level of the synapse. That is, For example, norepinephrine and serotonin levels can be manipulated by providing antidepressants. And when you make more of those neurotransmitters available at the level of the synapse, then that typically reduces symptoms of depression. So you treat it at the level of the cause, which is in some instances at the biological level. So different methods that would be considered to fall into the biomedical category, that is psychosurgery, for example. This is operating on the brain. There's a particularly a loathsome procedure known as the prefrontal lobotomy that was used and abused prior to the advent of psychotropic medication that reduced symptoms. So historically, we treated our mentally ill folks, our people with psychiatric disabilities, by housing them in large institutions. And the prefrontal lobotomy became an administrative tool because you had literally thousands of people with intractable symptoms that were very, very difficult to manage in some cases. So the prefrontal lobotomy is quite effective. It certainly reduced their symptoms, but it changed the person. The person emerged from the surgery a different kind of person than they were when they came in. They were docile, they were malleable, they were manipulable. Certainly, again, easier to manage, but it fundamentally altered the person's personality. There's other forms of psychosurgery that are used today in treatment of seizure disorders and so forth. I'm pretty sure nobody gets lobotomized anymore. And the electroconvulsive therapy, this is when electrical current is passed through your brain. It has the effect of reducing symptoms of major depression quite effectively. So this is often a sort of a last line treatment for people who haven't responded to any sort of medical other treatments for their depression. ECT is often quite effective. It has some downsides. For example, some people will lose memory for certain things, and in some cases these memories can be recovered. In other cases they can't. And then the drugs or the pharmacologic treatments we're going to talk about in the next lecture. But there's a number of different biomedical therapies that have been used and that are currently used to treat psych disorders at the biological level. All right, so let's look at the behavioral therapies now. And we'll do this through case study number 2. Mr. Bond is a divorced 50-year-old male. His wife, that was Mrs. Bond, of 20 years, had initiated the divorce 3 years prior. His present girlfriend, Stephanie, is putting pressure on him to deepen their relationship and possibly move towards marriage. Now, whenever Mr. Bond is with Stephanie, he feels a deep sense of dread, and his thoughts, which are catastrophic, often race out of control. For the past 3 months, whenever they are together, his heart pounds, he feels short of breath, he gets dizzy. As a result of his feelings, he is spending less time with her and is contemplating leaving Stephanie. Physical examination and other investigations are normal. So what do you suppose Mr. Bond is suffering from? What's your diagnosis? Well, sounds like he's experiencing anxiety, of which there are a number of different subtypes. Maybe his symptoms reflect some sort of phobic response because they're particular to the time that he spends with Stephanie. Treatment: you decide that Mr. Bond's phobia is not specific to Stephanie, so it's not Stephanie phobia, but rather he's responding more generally to situations involving emotional intimacy. And you initiate behavioral and cognitive behavioral therapy. So we'll look at these therapies in turn. So behavioral therapy, generally the goal of this type of therapy is to identify the environmental factors that evoke troublesome behavior and to change the maladaptive behavior learned. Remember that behaviorists view our responses as being acquired, that is, we've learned them. These behaviors have been learned through operant or classical conditioning and observational social learning. So the idea is that if maladaptive behaviors and responses can be learned through the processes of classical, operant, and observational learning, they can be unlearned through these same processes. Methods. So some of the behavioral methods include aversion and exposure techniques. These are techniques that involve, let's start with aversion. For example, if somebody has a problem with alcohol, one method is to provide them with a drug called antabuse, and what antabuse does is make somebody violently ill every time they take a drink. So what a person would learn is that there's an association between drinking and becoming violently ill while on these medications, and so they would avoid alcohol because they don't want to become violently ill. Exposure techniques. These are used in some cases with individuals who have phobias. Let's say somebody's got a phobia of snakes. So the idea would be to expose them to snakes, immerse them in the object of their fear. So you might give somebody with such a phobia maybe a rubber snake, so they get used to kind of being around a model of a snake, a rubber model, and then you might advance their treatment such that they're holding an actual snake or they're proximate to an actual snake. So the idea is that once they're exposed to the object of their phobia and they don't experience any negative consequences, that is, they'll sort of unlearn the association. That is, they might even learn to have a more positive response towards the object of their fear. Shaping, modeling, and behavior rehearsal. I'm going to lump these together in an example. Social skills training, for example, is often used in cases with kids on the autism spectrum. For example, Asperger's is a disorder that we've heard a lot about these days, that we're hearing a lot about these days. So often these kids have a real difficult time socially at school because they have real difficulties assessing others' emotional state. And this is important to be able to do. So if you're a kid playing on the playground, it's important to be able to discern where other people are at emotionally. And we do this as a part and parcel of our social intercourse. Our learning to be with other people involves being able to be empathic, to step into other people's shoes, to take their perspective, to discern, hopefully with some degree of accuracy, what they're thinking, what they're feeling. And so kids with Asperger's syndrome have difficulty doing this. So they often have problems relating with others effectively. So if you're working with a child who, for example, wants to improve their ability to interact socially on the playground or in school, for example, you might use social skills training that will use different behavioral techniques. Like shaping, for example, you learned in chapter 6, involves having a target behavior in mind. Suppose we want a child to be able to go up and introduce themselves to somebody on the playground. So that's the end goal behavior. So how would we support the learning that needs to happen to accomplish or achieve that end goal target behavior? Well, by shaping the behavior, you would reward successive approximations of it. So you might set up a role play where the child has as his or her task to approach an individual and say, hello, my name is, whatever. So as you're working with a child, you would reward successive approximations towards that end goal behavior. So ultimately, if they are able to perform the behavior, they would be at a sort of a steady state performance. So you would reward anything that they would do to advance them towards ultimately being able to do that, introduce themselves to somebody on the playground. Modeling would help. That is, you would demonstrate the behavior for them and you would help them rehearse it. That's behavioral rehearsal. And then another one I want to mention is systematic desensitization. We talked about this a bit in chapter 6, but let's take Mr. Bond's case, for example. Mr. Bond has learned to fear anything that signals emotional intimacy, and we've kind of laid this out. So the unconditioned stimulus would be emotional abandonment, which can reliably elicit a fear response. So you see this in kids. If kids are emotionally abandoned, then they're going to react with a fear response. And then the neutral stimulus was those signals of intimacy, whatever they might be, right? Being close physically to somebody, self-disclosing important aspects of one's inner life. So there's also there's a host of behaviors and so forth that signal emotional and physical intimacy. So prior to being emotionally abandoned, um, the signals of intimacy occur, and so Mr. Bond has learned to associate anything that signals emotional abandonment to react in an aversive way to that. So intimacy, anything that signals, hey, we're getting close now, emotionally, physically, and that sort of thing, we're deepening our relationship, triggers this fear response. So systematic desensitization, if we're going to treat Mr. Bond with systematic desensitization, the idea would be to weaken that association. Mr. Bond has learned to fear intimacy, so we've got to weaken that association. And the process of systematic desensitization involves two basic things. The first is to learn a relaxation technique, of which there are many. The second is to develop what's called an anxiety hierarchy. This is a list of scenarios involving intimacy that go from the scenario that produces the least amount of anxiety and fear to the one that produces the greatest amount. So the idea would be to work with the therapist and hatch the anxiety hierarchy and to learn the relaxation technique, and then work through the anxiety hierarchy with Mr. Bond until Mr. Bond is not reacting with fear and anxiety to those signals of intimacy, but rather maybe he's reacting in a new, more adaptive way to relax. All right, cognitive behavioral therapies are next. So let's take a look at these. So we'll look at cognitive, and there's a subtle difference between the two. So Aaron Beck came up with cognitive therapy. The idea is that cognitive therapy will change irrational beliefs. So the methods involve really kind of digging in and working with somebody to identify their irrational beliefs. And employing techniques such as thought stopping to get people to stop thinking irrationally. So, for example, Mr. Bond might maintain the cognition that closeness will inevitably lead to pain, given his experience with closeness. And so, what a cognitive therapist would do is identify that irrational cognition, because closeness will not necessarily inevitably lead to pain unless you have a crystal ball and you can look into the future. This would be an irrational belief because there's no basis for it. There may be a basis for feeling this way and thinking this way based on one's past experience, but going forward, it doesn't really make sense. So the idea would be to stop the occurrence of these irrational beliefs. So thought stopping is a technique that simply involves you identifying when you're having the irrational belief and then sort of yelling inside of your head, stop, stop. So the idea would be to arrest the irrational belief, identify and arrest and stop, reduce the irrational beliefs. Then cognitive behavioral therapies involve, and they're very similar to cognitive, but they involve a more of a focus on the behavioral or the consequences of the irrational beliefs. So the idea is, again, to identify the irrational beliefs and their associated consequences, which include behaviors. So one method we get from Albert Ellis, the rational emotive therapeutic technique. So in Ellis's view, when we have an irrational belief, for example, closeness will inevitably lead to pain, there's some activating event, there's some context that triggers that irrational belief that closeness will inevitably lead to pain. So there's an activating situation or context, probably with Mr. Bond, it's being around Stephanie, that triggers that belief. And then the consequences of that belief being triggered are various emotions that somebody has, like anxiety and fear, and then the behaviors that accompany the irrational belief, that is distancing. Mr. Bond is distancing himself from Stephanie, which will bring probably some closeness sneaking on behalf of Stephanie, and then you get into a conflict when you have a one that's in the role of the distancer, and then the one in the role of the pursuer. This is a recipe for conflict in a relationship. So the idea is to change that irrational belief, to identify the belief that's irrational, and then if you change the belief, you're going to see a change in the consequences. That is, I change the belief, I'm going to have a change in the emotional reaction that I have to the belief, and I'm also going to change my behavior. So if I can somehow modify this belief that closeness will inevitably lead to pain, such that I come to understand that it's irrational, that closeness is actually okay, I might change my emotional reaction to somebody who's seeking intimacy, emotional or otherwise. I might change my behavior. All right, so concept check here. Behavior therapist's major concern in treating an abnormal behavior would be to discover A, the unconscious conflict that led to the behavior, B, how environmental factors are evoking the troublesome behavior, C, the ways in which behavior keeps the client from becoming self-actualized, D, the inappropriate thought patterns that underlie the behavior. Correct answer is B. Behaviorists look for the environmental factors that elicit or evoke troublesome behavior. So, troublesome behaviors have been acquired. They've been learned by experiencing the consequences of our actions, by landing in certain antecedent conditions where we've acquired a certain set of responses. These are behavioral tendencies. So you change the triggers, you might change the behavior. Change the consequences, you might change the behavior. All right, so now let's continue with our look at psychotherapies by looking at insight therapies. These are the ones you're probably most familiar. Talk therapies, for example. If you have a trouble, what do? You go and talk with somebody. Well, this wasn't always the case. So we can thank Sigmund Freud and psychoanalysis for really beginning what we now know as talk therapy. So we'll look at the psychodynamic view first, and then we'll look at Carl Rogers' humanistic or client-centered therapy. All right. So psychodynamic, or this psychoanalytic perspective, the goals of traditional psychoanalysis is to make the unconscious conscious. That is, there's all these forces in conflict that we are unaware of, repressed desires and so forth, that are bubbling up and creating problems in our relationships, in our personal lives and so forth, our work lives. So the idea would be to get at that unconscious stuff, make it conscious, so that we can gain rational control over it, and ultimately change our personality structure. We become a different person. We are transformed fundamentally through psychoanalysis. Methods, primarily free association. This is when an individual is encouraged to speak openly, freely. So if you look at this image down here, this is an image of Freud's consulting room. So the typical traditional psychoanalytic setup would be the client would come in, get comfortable on a couch or a chair, and then the analyst would be seated out of view of the analysand, or the client or the patient, and then the patient would be encouraged to kind of speak freely. And this could be about what's going on for them today, what happened yesterday, how are they doing emotionally, which might lead to a exploration of of their developmental history, their past, and that sort of thing, and how the past relates to the present. Um, the analyst isn't passively sitting there doing nothing, but rather is very active in the process. In fact, their role is that of interpreter. So the client or the patient would talk about their lives and their emotions and their thoughts and so forth. And then the analyst's role is to help the client make sense of all that with respect to the problems that they may be experiencing, to create hypotheses about what may be going on for that person, how their present might be linked to their past, what happened to them as a child, and so forth. Freud was an advocate of dreams and dream interpretation, bringing dreams into the therapeutic relationship. One of his most uh, well-known works is his book, The Interpretation of Dreams. Freud viewed dreams as the royal road to the unconscious, so to speak. That is, certain aspects of our unconscious life are revealed through our dreams through symbolism. Um, the manifest content of a dream is what you actually see, and then the latent content is the meaning. So to explore dreams and their latent meaning was very important in traditional psychoanalytic approach. Other things that are happening in the consulting room are resistance. For example, you might expect somebody to attempt to sort of sabotage the therapeutic process, particularly when you're there with an analyst who you don't know. There's got to be a tremendous amount of trust for this person who you're going to be revealing your deepest, darkest secrets to. And so you can expect a certain amount of resistance to that process on behalf of the patient or the client. And I like to use a medical analogy. So let's say you have a sore shoulder. Well, if you go to the doctor's going to kind of probe around, palpate the painful area until maybe he or she hits a spot that's particularly painful to really kind of find out where the damage might be. So you can think of a psychoanalyst as somebody who's sort of probing around, but in your psyche. So you're poking around in somebody's psyche until you kind of get close to the place where the pain is. And what do you do when you experience that? Well, somebody's poking around in there, you start poking around, and you're going to withdraw reflexively. You're going to resist that. You're going to pull away if something hurts. And you see this in therapeutic relationships. That is, maybe you start to make some progress, and you're getting close to something that may be deep and hurtful and painful for the person, and then the person begins to cancel appointments. They might block the process in certain ways, and then the therapist, again, as interpreter, has to, you don't get defensive about this, like you don't get angry. Why are you missing so many appointments? No, you don't. You say, well, here's what I've observed, and I want to try to make sense of this if possible. I've observed that you've canceled our last 3 meetings. Here's a sense I make of that. I wonder what you think of it. So I think we were just kind of starting to get somewhere. We were getting close to something that may be important to you, and then that's associated with you missing these appointments. So I think you might be blocking, you're resisting. What do you think? So you use it as a therapeutic technique. And then the last one I wanted to mention here is analysis of transference. So transference is something that is kind of interesting that happens in therapeutic relationships. So what transference is when a patient or a client begins to sort of bring in stuff and baggage that they've experienced in their past relationships, for example, into the therapeutic relationship. So, for example, a patient begins to really get angry with the therapist routinely. So it could be that the person has learned that to be in closeness with another person, maybe their mom or their dad or something like that, involved a lot of anger and mixed feelings and ambivalence. So they're bringing that, they're repeating that in the therapeutic relationship. So again, what we've experienced in our past and what we've learned in our past is sort of being transferred into the current existing relationship. So what the therapist has to do, again, is act as interpreter. The idea is to take that transference and analyze it. Say, okay, I've noticed that you're getting angry at me. I'm not going to act defensive and I'm not going to get angry back at you. I'm not going to do that. But what I'd like to do is take a look at this anger that keeps manifesting itself in our relationship and really kind of explore that. What's going on here with anger? We're getting closer. We're getting, I feel that we're having a relationship here. Trust is developing, and now this anger is starting to appear. So you explore that transference. You don't react to it negatively as a therapist, but rather you bracket it aside and you use it to support the therapeutic process. All right. Historically, psychoanalysis took years in some cases, and it was really kind of reserved for the wealthy, because only the wealthy could afford to do traditional psychoanalysis, which would be going to the therapist 2 or 3 or more times a week for 2 or 3 hours. So traditional psychoanalysis is not practiced very much anymore. But certainly we can take away much of what Freud developed as an analyst and incorporate into some of the things that we do as therapists. Not that I'm a therapist, but certainly therapists borrow from a number of different techniques to support the well-being of their clients. All right, so to deal with his relationship issues, Mr. Bond entered psychoanalysis. However, as the therapeutic relationship deepened, Mr. Bond started to feel that his therapist truly cared for him. As a result, he began to pull away from him, suddenly canceling appointments, clamming up, etc. Mr. Bond is displaying feelings and behavior that psychoanalysts referred to as D. He's resisting as he begins to experience closeness with his therapist. Maybe this is triggering that fear of intimacy. And so he's backing away from that. So that's resistance. But it could be also transference because he's anticipating the same sort of consequence of closeness with his therapist that he experienced in the past. That is, when I get close to somebody, what's going to happen? I'm going to be emotionally abandoned. So he's bringing that past stuff, past experience, learning he's done into the relationship with this therapist. So maybe a little bit of A and D going on there. All right, so let's take a look at the humanistic approach. Again, this is another kind of insight. The idea is in insight therapies generally is that if we can gain insight into the source of our problems, then we can gain some sort of rational control of them and move forward. So Carl Rogers, somebody who's you're familiar with at this point, developed his own brand of therapy known as person or client-centered therapy. And I'd like to read this quote because I think it really captures the essence of humanistic therapy or client-centered therapy. Life at its best is a flowing, changing process in which nothing is fixed. So Rogers believed that we as an act of will can change and grow. If we can understand ourselves and what we believe and think about ourselves, then that's sort of the starting point for change and growth. So the goals, here are a few of them: to foster self-acceptance and personal growth. So we learned about in the section on personality is that some people experience sort of this disconnect between their ideal selves or their ought selves and who they really believe themselves to be. There's incongruity. They lack congruence between their self-image and sort of these ideal selves and ought selves. And the world is telling them one thing and they're believing something different about themselves. So the idea is to foster that congruency and accept oneself as one is, strengths and limitations, as the starting point for personal growth. To restructure the self-concept to better correspond with reality. So beliefs that you have about yourself, essentially that's what the self-concept is. It's this collection of beliefs, self-cognitions, the person that you believe yourself to be, and how that maps on to reality. So is the world telling you you're an awful, terrible person, or not? So that would be the idea, to foster that congruence, increase self-esteem, um, boost that positive self-image, and to reduce the need to live up to the expectations of others. Remember that incongruence is largely fostered by conditional positive regard experienced as a child. That is, a parent makes their love and affection contingent on a child being who the parent wants or needs them to be. So the idea would be to stop trying to live up to the expectations of others and focus on oneself, finding out who one is, and then going forward from there. And then to help this person fulfill their potentiality. So the idea would be to find out who one really is, what one's strengths and limitations are, and then go forward from there to maximize one's personal human potential. Methods include authenticity. So Rogers believed that many of his patients had experienced incongruence, that is, a disconnect between um, who they believe themselves to be and what the world is telling them to be, largely due to conditional positive regard that they experienced as young people. And so essentially they learned to be somebody who they were not. They hadn't experienced what it meant to be real, to be authentic as people. So what Rogers endeavored to do would be to model this authenticity. What is it like to be genuine, to be who you are? Um, and so Rogers would model that kind of behavior for his clients, um, hoping they would benefit from his authenticity, his being real. Communicate caring and non-judgmental understanding. And this ties in with the third one: practice participative and empathic listening. So the idea is that you're not there to judge somebody. You're rather there to convey, and this is the last one, that unconditional positive regard that perhaps they didn't experience early on that might have been beneficial. Empathy is huge. It's very, very important ability and aptitude to possess as a therapist, particular client-centered therapist, because you've really got to be able to step in to somebody else's experience, to see the world the way they see it, to really feel the way they do. And maybe sometimes for the first time, somebody um, feels like they're being seen, they're being heard, for who they are, as opposed to who somebody wants them to be or expects them to be. So you can think of this as being the good enough parent, reparenting people, delighting in their presence, helping them find who they are, helping them take stock in who they are, and give them that secure base upon which to move forward and out into the world. So we talked about some of these approaches, psychotherapeutic approaches. What's best might be an important question to try to ask and try to answer. So it depends on the problem. So for example, if somebody's clinically depressed, Mrs. Bond, for example, if she's clinically depressed, no amount of talk therapy or insight therapy will do much good if the person can't get out of bed, and they're struggling with deep depression. So in this kind of case, you'd probably want to consider some sort of biomedical therapy, um, like antidepressants, and then that in conjunction with some sort of insight therapy. But it depends on the problem, largely case by case. Also depends on the therapist and the client and their relationship. So this is really important. In fact, this therapeutic relationship is really tantamount to success. I mean, or it has to, you have to establish the trust to be able to work with somebody. So certainly therapists have different styles, they have different personalities, as do clients. So a lot depends on the people and their ability to relate effectively as client and patient. Many therapists use a blended approach. That is, there's so many different types of psychotherapies that to choose from. Really, the best you can do, really, the best service you can provide is by looking at your client's particular situation and then using, borrowing from any number of these. This is the blended approach. So it could be that, and I think the research bears this out. And of course, it depends on the issue, but usually this blended approach is most effective. Um, for example, in cases of major depression, drug use, or excuse me, maybe antidepressants in conjunction with some other form of psychotherapy, either insight or cognitive behavioral, has been found to be most effective, rather than just medicine alone. No evidence to suggest that theoretical approach, that is, whether you're a Freudian or a Rogerian or somebody that practices Albert Ellis's rational motive therapy or whatever, that theoretical approach alone makes one therapist more effective than another. It's the personal skills of the therapist that makes a difference. So really, um, when you're looking at a therapist, what makes a good therapist, and there's certainly variability among therapists, just like you would find in any other profession. Some people are better at it than others. So it's the personal skills, that is the ability to make the connection with another human being, for example, is so important in working with people who are struggling with certain issues. All right, so let's do a little practice here. The idea is to name that therapy. So therapist number one, Doctor Who's therapeutic approach stresses the importance of the unconscious and dynamic forces in psychic functioning. What type of therapeutic approach does Doctor Who adhere to? That would be psychoanalysis, insight. So the psychoanalytic folks are looking to the unconscious conflicts and repressed desires and so forth, repressed memories, to make the unconscious conscious so we can gain some rational control over that stuff that's influencing our current life. Therapist 2, Dr. Jones's therapeutic approach stresses the importance of identifying environmental factors that can evoke maladaptive behaviors. Jones's credo is what has been learned can be unlearned. What do you suppose the type of therapy Jones practices is? That would be behavioral. Therapist number 3, Dr. England's therapeutic approach stresses the importance of identifying an individual's irrational beliefs that result in erroneous and damaging self-appraisals. Type of therapy? Cognitive. Therapist 4, Dr. Clementine's therapeutic approach stresses the importance of establishing a warm, caring relationship with each patient and on their potential for psychological growth. Type of therapy? That would be humanistic or insight therapy. So humanistic is a form of insight therapy. Dr. Smith's therapeutic approach stresses the importance of treating the symptoms of disorders at the biological level, mainly with medicine. Type of therapy? What category does this fit into? Biomedical. All right, so here's the learning objective. Take a look at these, study them, learn them. Take care.